All right. I want to welcome everybody back to the Biochemical Genetics Clinical Core Seminar Series. It's October 18th, 2024. This is week 14 of the series for 2024, and we're happy to welcome back Dr. Bill Wilcox from Emory. He's going to be talking about lysosomal storage disorders. The code will be in the chat. Thank you, Sarah. LARRAS for CME credit. This will be archived as per usual at simd.org under the education piece alongside NAMA. And if you have questions for Dr. Wilcox during the discussion, you can pop them in the chat. We'll try to get to them during, but maybe after. Bill, I'll leave it up to you as to how you want
Okay.
to. Next week, we have Dr. McCandless, Sean McCandless, talking about novel therapeutics in metabolic conditions. And I think that's it for announcements. I'll give it over to you, Bill.
Okay, thanks. There are my disclosures. What I'm going to focus on today is neurologic LSD that don't have as much outward somatic symptoms like we discussed in the last session. So what neurologic things are we looking for? And this could be caused by many things. So it isn't like it's just an LSD. Loss of acquired developmental milestones, behavioral changes, psychosis in adults, seizures, ataxia, neuropathy and neuropathic pain, macrocephaly, in the eye, corneal clouding, ophthalmoplegia, particularly vertical for Niemann-Pick C, and retinopathy. So we're going to start off with GM2 gangliosidosis. This is autosomal recessive, and it's due to deficiency in either hexosaminidase A or both hexosaminidase A and B, or the GM2 activator protein. So hexosaminidase A is made up an alpha and beta chain from hex A and hex B. It degrades GM2 after it's presented by the activator protein and removes terminal hexosamine from GAGs, glycoproteins, and glycolipids, just like hex B can. Hexosaminidase B is a homodimer of the beta subunits that come from the hex B gene. And this produces two different diseases, Tay-Sachs, which has hex A deficiency and stores GM2 ganglioside in the brain and nerve cells and in the retina, and Sandhoff disease that is combined hex A and B deficiency due to mutations in the hex B gene. So looking here at where Tay-Sachs and Sandhoff fits in, this is from the Soderbray's book. And I think this diagram is pretty nice. So complex gangliosides get broken down into GM1, and deficiency of this enzyme, the beta-galactosidase, produces GM1 gangliosidosis, we'll talk about in a minute. And the next enzyme down is hexosaminidase A, with the GM2 activator protein, and deficiency in cleaving off this terminal GalNAc produces Tay-Sachs and Sandhoff's. Sandhoff also has a deficiency in breaking down GB4 and other things. So that's why the phenotype's a little different between the two. Infantile Tay-Sachs appears normal at birth, but they do have storage. If you did an autopsy on babies or even terminated babies that have storage already. Loss of motor skills started at 3 to 6 months with weakness and an exaggerated startle. They develop decreased vision over time and a cherry red spot. I'll show you a picture of that. And they develop macrocephaly over time and often seizures. And without aggressive intervention, they typically die by age 2 to 3. So this is the normal retina with the optic nerve and the fovea and the macula. That's where our central vision is. And over time, this as storage occurs in either Sandhoff or in Tay-Sachs here. you get atrophy of everything except the fovea. So that's the only thing left that's still surviving. And all the rest is the retinal pigment epithelium is dying back. So it becomes pale. It changes color. And you can get brown spots, black spots, or red spots. But it's pretty obvious there's this clearing that's around the fovea. Subacute juvenile Tay-Sachs, they're normal until about age 2 and then develop abnormal gait and dysarthria, spasticity, and lose skills. They may develop seizures and vision loss as well. And they will die by the second decade unless it's a rapidly progressive case. And that's sort of I think, a theme in a lot of CNS diseases. There's people that progress rapidly and those that progress much more slowly. And the difference between them, people hypothesize it's neuroinflammation, it's other genes, whatever. We don't really understand all of it. And it's variable even within families as to how fast they're going to progress. Late onset Tay-Sachs presents with teen to adult years with dysarthria and lower extremity weakness, poor coordination, ataxia, spasticity or dystonia, tremors, and 40% have psychiatric symptoms. It slowly progresses. It's variable within families. And this is what we just finished a clinical trial on with substrate inhibition. So late onset Tay-Sachs, they start off with this is control brain. In early disease, they start getting shrinkage of their cerebellum, which gets worse over time. And the rest of the brain is much more preserved, and atrophy is slower. Really hits the cerebellum first. Tay-Sachs can be diagnosed by enzyme assay, low hex A with a normal or increased hex B on the enzyme assay. But keep in mind, there's a pseudodeficiency. There's several different mutations that cause it, and it's relatively common. There's also the annoying B1 variant, and there are several mutations that do this that have a normal enzyme assay with artificial substrate. So you can get false negatives. In a lot of enzymatic things we do, this isn't real common, but this is more of a problem with Tay-Sachs. So keep that in mind. If you really think the person's got Tay-Sachs, you got to have the molecular to back you up. The AB variant due to GM2 activator deficiency would have normal in vitro activity because it's got mutations in the GM2, and it's degrading the natural substrate that's the problem, not the hex A itself. Hex A has many, many mutations. Most of them are pretty well defined at this point. There are some distinct founder mutations in different populations. Tay-Sachs is common in Ashkenazi Jews, and that's why carrier screening is done in that population commonly. And in the very Orthodox community that have matchmaked marriages, they do all the genetic carrier testing. It goes into a database. Toria Sharam decides who gets to marry who, so they don't put two carriers together. There are two common founder mutations. In the Cajuns, they have two founder mutations. One is the same as the common Jewish-associated mutation, which is a frameship termination. There's an Eastern Quebec French-Canadian mutation that's a deletion, and the Pennsylvania Dutch have a founder mutation as well that's the same as the Cajun-associated one. Sandhoff is much less common than Tay-Sachs. The infantile form is neurologically similar to Tay-Sachs, but may have organomegaly at the same time and skeletal abnormalities. Juvenile form that has later onset has regression and dysarthria and gait problems, and there's a late onset form that's more ataxic memory and executive problems. That's similar to the late onset Tay-Sachs. Clinical trials have been done for this. Pyrimethamine was tried, and it's a weak chaperone for Hexa, and the results are not very consistent. Miglustat had poor results. That's substrate inhibition. Venglustat trial with substrate reduction was just tried for late onset Tay-Sachs, and it failed. But it failed, I think, in an instructive way, because the patients who are on the control arm and the patients that were in the treated arm, there were groups of patients in each one that got better, that were able to walk more, that seemed to even have better reflexes, even though they were on placebo or treatment. So you couldn't tell the difference between the two. So if there was, a subset that was really responding, you wouldn't be able to tell. But it says that, encouraging these people to do some exercise and lose some weight and get some physical therapy made a difference. So that's what I told my patient that was on it. Turned out she was on the drug arm. I said, you may have done all this yourself. And she was able to start going up curbs again and got out of the wheelchair and was walking again. So it's like, okay, this could be all you. There's another inhibitor of synthesis that's a little broader, that's proposed for clinical trials, and I don't know the status of that one, that AZ3102. N-acetyl L-leucine decreases neuroinflammation, and it's been used for late onset GM2. And the early results look okay from like a phase 2 study, but they'll have to study more patients in a blinded way to know for sure. And then there's gene therapies that are kind of early. There are not a lot of patients that have been done yet. So I'd say we still got a long ways to go on GM2. The Venglustat trial was a disappointment. Turning to GM1 gangliosidosis, this is the prior step before GM2. It's rare, it's autosomal recessive. It's due to deficiency of beta-galactosidase deficiency. And beta-galactosidase deficiency can produce anything from high drops to adult neurodegenerative disease to Morquio-B. The diagnosis is suggested by increased urine galacto-oligosaccharides and sometimes keratan sulfate. If you're doing screening oligos and GAGs. Enzyme assay with neuroimidase needed to exclude galactosialidosis unless the molecular is telling you exactly what's going on. So this is the step ahead of time of GM1 gangliosidosis, this beta-galactosidase deficiency. So you just build up this. Juvenile GM1 has an onset of 3 to 10 with ataxia, impaired gross and fine motor skills, and dysarthria. They may develop corneal clouding and organomegaly and cardiomyopathy, and a short stature plus or minus mild dysostosis multiplex, and they're at risk for odontoid hypoplasia and develop cerebral atrophy and death in their second decade. Chronic / adult GM1 has an onset from late childhood to the third decade with dystonia and unsteady gait, may have psychiatric symptoms, speech and swallowing problems, short stature, and may have a mild dysostosis multiplex, and may develop cardiomyopathy over time. Here's the MRI findings over time. So they start off pretty normal, and then they develop this posterior white matter disease, and then iron deposition in the globus pallidus. So there's lots of different iron, storage diseases that have secondary iron storage in the brain, and this is one of them. The treatment trial so far, there's gene therapy, two different intercisternal AAVs in up to 3 years of age, and an IV AAV9, 6 months to 12 years of age. I haven't seen any results yet. And substrate reduction with venglustat was tried in the secondary population in the Tay-Sachs study. I don't know if anybody's continuing on it. I've got a sialidosis patient who's continuing late onset sialidosis because she seemed to objectively do better. But again, that was open label. All the secondary population was all open label. Turning to metachromatic leukodystrophy, this is autosomal recessive deficiency of aryl sulfatase A. There's a storage of sulfated lipids in the central and peripheral nervous system. It has its onset from infancy to older adults, and it's diagnosed by enzyme assay urine sulfatides and molecular testing. There's a common pseudodeficiency allele that is homozygous in about 2% of the population. And because it's so common, it can be in cis with a pathogenic mutation. So you got to sequence the gene. That pseudodeficiency is the nightmare for newborn screening. If you're going to do an enzyme assay, then you've got to have some backup of thing that you're going to look at because you're going to get a fair amount of pseudodeficiency alleles in there. There is it's a pan-ethnic disease, but there's a founder mutation in Eskimos and in the Western Navajo if you treat those groups. So here's the enzyme for metachromatic leukodystrophy, aryl sulfatase A, that uses sapacin B to work so you could have deficiencies of sapacin, which produce a different disease, galactosialidosis. And this is sulfatide, so it's a sulfated galactose, and the enzyme removes the sulfate group. Late infantile metachromatic leukodystrophy, that's constitutes a decent proportion of the total number of patients. It has its onset under 30 months of age with hypotonia, weakness, toe walking, dysarthria, decreased reflexes, and slow nerve conduction, and they will regress and often develop seizures, pain. Not a pleasant disease for the kids, and can take them quite a while to die. And this is the one that therapy has been targeted towards, and efforts towards newborn screening, which is in pilot studies now. Juvenile metachromatic leukodystrophy, this is the next most common group with onset of 30 months to 16 years, decline in school performance, behavioral and gait problems, and they develop the other problems just like the more severe metachromatic leukodystrophy, and it just progresses more slowly. And adult MLD, the last group, has an onset much later and often with personality changes and psychiatric problems. So some of the smarter psychiatrists test for this when they've got a new onset psychosis in adults, or they're doing an MRI and seeing the changes on the MRI. And they may develop a neuropathy and spasticity over time, and it's slow decline in these patients. So here's what you see on an MRI, and you may notice this kind of tiger striped appearance or this leopard spotted appearance, like here in the white matter and here. This is characteristic of this disease when you see it. How is it treated? So until recently, exclusively with bone marrow transplant, ideally done prior to symptoms. It takes about 6 months to engraft. and start getting enzyme in there in the CNS, and so early in the course for juvenile or adult patients. Now there's approved in Europe and in the US an ex vivo stem cell lentiviral gene therapy. So they give you medication that makes you release your bone marrow stem cells. They harvest those, then they transfect them using a lentiviral vector that will integrate into your DNA, and unfortunately a little bit too randomly, but that puts a gene in, and so therefore those cells express a lot of enzyme, unlike a bone marrow transplant. It's like a transplant needs to be done early, but it's going to express a lot more enzyme and does better than standard bone marrow transplant has done in the past. Very expensive, as you might imagine, and it's per patient driven. There's going to be very few sites in the U.S. that are doing this. Emory Children's Hospital is one of them, and so if you end up getting one of these kids early enough, we're a potential site for them to get their gene therapy. There's a phase 2 trial of intrathecal enzyme replacement, didn't work, failed. There's a trial of intravenous enzyme replacement in those with prior stem cell transplant to at least try and address their peripheral symptoms better than transplant is. And there's a intracerebral AAV gene therapy gene transfer trial that's out there as well. But for right now, looks like the ex vivo gene therapy followed by transplant is the way to go. And then you don't get graft versus host disease because it's the patient's own cells that you're putting the gene in. And this is from the clinical trials. So this is the year 2 and year 3. So if we look at year 3, and this is motor function scores, this is late infantile disease, and this is early juvenile. These are the untreated natural history patients and how they're functioning. It's like hardly at all for the late infantile, and early juvenile very poorly, compared to this group who showed stabilization of their motor scores from year 2 to year 3. It's really not changing, which is great. Then turning to one that's not quite as a happy a story as Krabbe disease. That's autosomal recessive. It's about 1 in 250,000. It's due to deficiency of galactosyl ceramidase. There's infantile to older adult presentations. The diagnosis is made with an enzyme assay and molecular testing of the GALC gene. There's a common 30 kb deletion mutation. It's 45% of the pathogenic alleles. And if you're homozygous for this, you have the severe form, obviously. And there are pseudodeficiencies that are relatively common. There's some genotype-phenotype correlations that are available. There's a group that meets to discuss newborn screening cases or diagnostic cases. You're trying to figure out what that genotype means and what to do with the individual patient if they're pre-symptomatic. So this is the galactosyl ceramide, and the enzyme cleaves off that terminal galactose to make ceramide. If you're not able to do that, you can get rid of one of the fatty acid side chains. There's an enzyme that does that and makes this galactosyl sphingosine, which also goes by the name psychosine. And that's the biomarker that is used often for newborn screening, because there's so many pseudodeficiencies, so many different variants of unknown significance that have been found in newborn screening in mixed ethnicity populations like New York, where they have the most experience. So cycosine is really helpful for those of us who have similar mixed populations. So its onset is for early infantile, less than 12 months. It turns out to be less common than the later onset form. They present with extreme irritability, developmental delay. They progress to spasticity. They regress and have feeding problems. They have a peripheral neuropathy, and they die by age 2, unless you're putting them on ventilators or something. They have little to no enzyme activity and 2 severe mutations. They have elevated CSF protein, and their cycosine on the newborn screening or shortly thereafter is greater than 10 nanomoles per liter. So that's the cutoff that we use to determine urgent transplant or not. So these are the MRI findings over time in this group of patients. So here early on, things start off pretty normal. This is the brainstem and cerebellum. And then by 18 months, here's posterior periventricular leukodystrophy and atrophy here of the pons and brainstem area. And here there's more extensive leukodystrophy and more atrophy that's going on. Early childhood Krabbe is slower development or regression, and then slurred speech and hypotonia. And they may have esotropia and vision loss, seizures and neuropathy, and also have abnormal nerve conductions and hearing and visual evoked responses. And later onset Krabbe presents with weakness and behavioral changes, and they may have decreased sensation and burning paresthesias. And they may not have increased cycosine and a slow decline. So you're really dependent on your enzyme assay and your molecular testing for this. So what's the treatment? At least for the infantile form, transplant prior to a month of age. This has had mixed results. Many have had significant disability, even if done this early, which I can tell you is not easy to do. To do all you get the newborn screening, to do the confirmatory testing, even if you put them in the hospital right away, which we do, and do all the pre-transplant assessments and talk to the family and have everything ready to go and deal with all the insurance issues for a transplant. Trying to get everything done within a month is a challenge. So you have to prepare for this ahead of time. You have to know exactly what you're going to do with one of these patients if you're going to have a newborn screening program. If you don't have the resources in your state, you need to have an identified transplant center with approval from your state Medicaid to send the patient out. So you need to prepare for everything before you start your newborn screening, because otherwise you won't get the transplant done in less than a month. So it sounds like a nightmare, it's because it is. And it's an all hands on deck for genetics and the transplant service when we get one of these. There's a trial of intravenous AAV Galaxy in patients that were previously transplanted. There was a trial of central nervous system delivered gene therapy, and I saw that program's now gone, so that it was canceled by the company. So I don't know if they didn't get good results or they just ran out of money, which is a problem with a lot of startups and gene therapies. They're very expensive to do. So newborn screening is on the RUSP for the infantile form, but not for everything. So how do you do that? I don't know. Because you're going to get these low enzyme levels. And it's difficult due to pseudodeficiencies and the variants of unknown significance. So we rely on, and which is really what the newborn screening on the RUSP recommends is cytosine second-tier testing. And we do that on a blood spot from the newborn screening card. So that just gets sent off when we get a low enzyme assay. And it's reduced false positives by a lot. So that's the way to go. And then are you going to have a lower cutoff for cytosine for kids that you're going to fallow for something that's later onset? That's each individual program has to make that decision because it's not on the RUS, but you're going to pick them up with low enzyme activity. And if you get a cytosine that's not normal for age, what does that mean? And do you need to follow them up? And follow up for the ones that have later onset disease predicted is difficult, as the New York's program could tell you. Many of them get lost to follow up over time. And you can't just follow cytosine. That doesn't tell you what's going on, because the cytosine may go down and they're still at risk, and it doesn't tell you if they're okay or not. So not ideal. Mucolipidosis 4 turning to a different disease that's more rare. It's recessive. It's most common in Ashkenazi Jews. There's a couple of founder mutations. They have accumulation of multiple lipids and GAGs in their lysosome. They get kind of a fingerprint pattern in their lysosome. Deficiency of mucolipin, a transient receptor potential cation channel. I'll show you a picture of hypothesized mechanisms for its pathogenesis. It presents with delayed development. They develop retinopathy and corneal clouding over time. They may have no acid in their stomach and develop progressive renal disease into their second to third decade. And rare, milder cases can just have isolated retinopathy or ataxia. So the initial stage of typical ML4, they present with slow development, mild visual impairment, and hypertonia, and then they get worse over time as they plateau, and then they begin to lose their skills, and that can go on for many years until they go into their declining phase, which can be more precipitous and slow onset of blindness to inability to do anything. And what they get over time is they start off with a thin corpus callosum, and their cerebellum is pretty preserved, and that will shrink over time. And then they get iron storage in their globus pallidus. Here's some proposed pathogenic mechanisms with loss of lysosomal iron efflux, defects in the mTORC signaling, loss of lysosomal calcium efflux, failure to make lysosomes properly, failure to make autophagosomes to recycle your bad organelles, and then problems in exocytosis, releasing things outside the cell, and abnormal things of mitochondria. So all of that just leads to the storage and cell dysfunction and cell death. So there's various parts of this where they proposed therapies. The only one where they've actually tried it in mice is this, where it's I can't see it. Okay, let's see. And yeah, I got the thing in the way. But anyway, it's a small agonist of this TPC2 protein. Somebody's not texting me about something. And that leads to improved function in ML4 mice. And the way that it works is it's increasing lysosomal exocytosis and autophagy. And so they're planning on doing a trial in humans. They haven't started it yet. And in vitro, at least, it also worked for Niemann-Pick and one of the Batten disease types. So, we'll see if any of this pans out once they start doing human trials. It's not going after the primary problem. So, turning to neuronal ceroid lipofuscinosis, this is a lot of different disorders. These are all neurodegenerative, and they have autofluorescent storage material. That's what defines the lipofuscinosis. And it contains lipids and proteins in the stored material, which is often fingerprint in under the electron microscope. Its onset from infantile to adult. They develop seizures and regression. Some have retinopathy, which may be the only finding in milder, older patients. There are 13 different genes. All of them are recessive, except for one dominant, CLN4. Diagnosis can be made by enzyme testing on 3 of them that have enzymes. But really, we depend on molecular panel testing for all of this stuff. So it's part of seizure panels, or it's part of, developmental panels, or just exomes, which I think we're doing a lot more these days rather than going for panels that basically they all use NGS anyway, and there's nothing to be gained by doing one of those. It's not like they're filling in any sequencing gaps like they used to do with panels. So these are the NCLs, and you can see the different types. I'm not going to go through this table, it's boring, but it's just ages of onset and seizures, and there's different ages of onset depending on how severe it is for each one of these. All the way up to CLN13. So talking about CLN2, which has a treatment that's approved, this is a boy with CLN2 disease, and this is FLAIR imaging, which is good for showing white matter disease. Shows hypointense thalamus here, and this white matter disease in the posterior limbs here. And then they develop volume loss over time. And here's showing this loss of volume, particularly of the cerebellum. There's different treatment approaches. There's enzyme replacement therapy. That's what's approved for CLN2. There's stem cell therapies that are being tried, mostly preclinical. There's I think an stem cell trial, oligodendrocyte stem cell trial. They're doing it at Duke. There's various gene therapies in early stages, preclinical or early clinical. Not a ton of movement on these things. I think there's just not enough money to do it all. And various pharmacologic things have been proposed, but most of them haven't panned out or moved very far in human clinical trials. So the one that's approved is intraventricular ERT for CLN2. So this requires you get a port and you go get it injected periodically. and it will delay the onset of symptoms in a pre-symptomatic patient. More symptomatic patients often progress, and that's often when we're doing the testing, is when they're symptomatic. And the retinal disease that they get will progress anyway. It costs a lot, which has caused caused our children's hospital to balk until they got threatened with embarrassment in the press for not providing it. But if you think about it, you look at the cost of these drugs, it's about the same as glycerol phenylbutyrate, which insurance companies fight about regularly right now. But that we use frequently. There's not very many of these patients. So now I'm going to turn to our last disease before we go to questions and stuff, is Niemann-Pick type C. And this is an autosomal recessive neurodegenerative disorder. They have a defect in intracellular cholesterol transport, leads to sphingosine storage and decreased cholesterol esterification. It has infantile to adult onset, and they have lipid-laden macrophages, and eventually they develop atrophy on their brain MRI. The diagnosis is made with elevated oxysterols. That's a suggestive test. It's not done at very many places. They do it at Mayo, for example. The old way of doing it was cultured fibroblasts and Philippine staining for the cholesterol storage, and molecular testing solves it most of the time with most of the mutations in the MPC1 gene. There's a second gene, MPC2, that accounts for the minority of patients. So there's different phenotypes. There's a visceral, early infantile with hepatomegaly and the liver dysfunction. Nothing's done about it. Will kill them frequently. And then there's a late infantile 2 to 6, and a juvenile 6 to 15, and an adult greater than 15. More neurodegenerative, and this has more psychiatric symptoms and neurodegeneration. With seizures are frequent in the more severe ones, ataxias in all of them, some degree of splenomegaly, particularly in the severe ones, and loss of function, and a vertical gaze palsy, which appears over time. It's not always present early on, but that's a useful sign if you see it. So this is, it has kind of a variable presentation. It makes it a little tough to make a diagnosis at times, and there's no enzyme assay that you can do. So molecular often finds these cases when you're just doing exome sequencing. The problem in Niemann-Pick C is trafficking cholesterol inside the cell. So normally you get unesterified cholesterol that comes in from the outside of the cell through the endosomes and goes to the endoplasmic reticulum or through the lysosome to the Golgi, and that unesterified cholesterol then gets esterified in these compartments and can be used for synthesis of things, and including your membranes. And here in Niemann-Pick, you aren't able to do that. So you aren't able to move your unesterified cholesterol to either the ER or the Golgi apparatus, which leads to the problems. So you get unesterified cholesterol accumulating and deficiencies inside the cell and overall. So that's where the problem lies. And how can we deal with it? What kind of treatments we got? So miglostat's been around for quite a while. It decreases sphingosine storage. This is a GCase inhibitor. So how does that work? I don't understand it very well, but it seems to increase survival on average it decreases the rate of decline of horizontal saccades in your eye movements. It's approved in some countries. It is off-label in the US and expensive. There's now 2 treatments that have been approved recently. Arimoclomol is one that just got approved. It increases HSP70 chaperone, has some other intracellular effects because it's not just chaperoning mutant NPC protein better, because it works. This was interesting. It works even on patients with functional nonsense mutations. So they're just not making any, say, NPC1, and it will still has an effect on those patients. So how it's doing that, companies exploring. We don't know. It slowed progression over a 1 year in a phase 2 double-blind study. And, the FDA originally rejected it. They went begging, and, the patient advocacy groups went back with the company to the FDA, and, it's better than nothing, so it's providing some benefit. So it was finally approved for use in conjunction with miglustat, which isn't approved for use in the US for Niemann-Pick C. That's an interesting combination. So now you got to use this approved drug with an unapproved drug for the indication. So that, I think, since I saw somebody from the FDA that's on this, that's something that needs to get addressed. So otherwise, people will be fighting with insurance companies to get the miglustat for their patients if they want to use arimoclomol. And we need long-term data. So there is extension stuff going on with the company, and I've told them this. I'm sure the Niemann-Pick groups have told them they better have long-term data that shows continued efficacy. I hope the FDA is requiring that for something that's adding on a big expense to miglustat already is a big expense. Another drug that got approved is N-acetyl-L-leucine. This, through unknown mechanism, decreases neuroinflammation. And in a double-blind crossover study, it showed improvement in ataxia scores while they were on, their short-term 6-month treatment. When they switched over, when the people who were on treatment switched to the placebo arm, they got worse again. And when the people on the placebo arm got switched to the active arm, they got better in their ataxia scores. So it really shows a decent improvement in many patients. But it was short-term. So we obviously need long-term data. These people are all on open label extension. So we'll see if the treatment effect is maintained over time to know which of these therapies is the best. I mean, you're not going to use all 3. You'd be breaking the bank if you used miglustat, arimoclomol, and N-acetyl-leucine, which have not all been tried together. So while that might sound intellectually useful, besides the expense, we don't have no idea whether it would work. So and I think there's much to be determined still about what's the appropriate way to approach a individual Niemann-Pick C patient. Another trial that's ongoing, that finished, was an intrathecal cyclodextran. I'll show you what that's like and how it works. So that got dropped. It showed some, the patients showed some disease progression anyway in an open label study. So nobody's doing that anymore. There is an IV cyclodextran trial that Cyclo is running for, there's one for liver disease that was being done out of WashU, and There's large doses for CNS disease. That's the phase 3 trial that Cyclo is doing. They're giving gram quantities of this through infusions. And when they go that high, it's able to scoot across the CNS, they say. So we'll see if this has a beneficial effect on human beings, or it was only helpful for animals. It's going to involve an infusion, but it has the potential of addressing the cholesterol transport problem and not just dealing with the neural inflammation that's coming from it, or trying to do something inside the cell to improve the way it's functioning, as the arimoclomol is doing. All the gene therapies, they're all preclinical, so nothing's clinical right now. So this is what the cyclodextran looks like. So looks like a donut, and the inside is hydrophobic and the outside is hydrophilic. Its pore is big enough to fit a cholesterol molecule, which is very hydrophobic. And so it just inserts itself in the cyclodextran, and that can capture it and can move it around in the cell and deliver it to the compartments where it needs to be. So that's the idea behind a cyclodextran treatment. Again, we'll see how well it works. Fortunately, this stuff you can give in gram quantities to a human being, and it doesn't seem to have big toxic effects. So now it's time for questions. I blew through this pretty fast, so we got plenty of time to chat now. So let's take you off of that and see what kind of questions we got here. All right.
So I was actually going to ask the same thing as Dalen just asked, and sort of to put it into context so you guys are screening for Krabbe
Yes, we do.
for the later onset patients or people who you think might be with lower cytosine levels. How do you follow them? I mean, is brain imaging a possible way to do it? Will you see, like in XALD, will you see MRI changes before you see symptoms?
Yeah, not real clear. I mean, our neurologist who follows some of these ain't real happy about it. Because what do you do with them? New York has published their suggestions for how to monitor them, but no one's going to do all of that. You're not going to be doing MRIs and CSF and nerve conduction and all that on a regular basis. So how often do you need to follow them, and will a family follow through with all of that while you're waiting to see what happens? Because the treatment's transplant and you need to do it early. But are you going to transplant somebody who might not have problems until they're an adult? As a child? I don't know the answer. Yeah, it's one of those unresolved things. And what's your lower level cutoff for psychosine when you get to pull them in and do the molecular testing and everything? Because we can't do second-tier molecular testing in Georgia. It's not part of the program. They have to get recalled to send samples. So that's always a headache when you're doing that. If we get a high psychosine, we pull them into the hospital so we can get everything done quickly, because you can't do anything quickly as an outpatient with molecular testing. Depending on insurance, it takes time. So I don't know what's the way we should manage them. What's the cutoff for psychosine if you're going to have later onset patients? That we're having a discussion about in the state. So not decided yet how we're going to do this. So far, we haven't gotten anybody that's had an elevated cytosine that had an abnormal newborn screen that wasn't an infantile. So we haven't faced it yet, but we're going to.
Yeah, I feel like we picked up, we're not screening for it right now in Colorado, but we picked up two kids within about 2 months' time with infantile onset who were symptomatic. And
Yeah.
a good discussion with Greenwood is where we sent we sent one sample of cytosine to them and one to Mayo. And I feel like Greenwood had a good amount of data showing separation between late onset and early onset. Um, Especially, I mean, the early onset infantile, those cytosine levels are well above 50, 60.
10, yeah. Yeah.
But I'm wondering if you could stratify it that way, if there's enough
Uh,
separation.
yeah, I'm not sure there's enough data right now. New York is doing its cytosine and its molecular testing and try to sort through all of that stuff. So I'm hoping they'll provide us some guidance because they have a lot of babies and their own molecular labs, so they can do things that we can't do in Georgia. I haven't. No, it wasn't gene therapy for Tay-Sachs. That was Venglustat. So the gene therapy is very early. So the Venglustat trial for Tay-Sachs failed. So the patients in the placebo arm and in the treated arm, there was an equal number of patients who deteriorated and those that got better.
Other questions for Dr. Wilcox?
Dual therapy for Gaucher. Yeah. So there is a trial. Results aren't available yet for type 3 for Venglustat. We're waiting to find out if that is going to help because it's CNS penetrant. So Eliglustat is not. Either Miglustat is, but I don't know that anybody's done a real trial of that in Gaucher type 3. But you probably have to use enzyme. It's not the most potent, and some of those people have quite a bit of storage. So Venglustat's being tried, I believe, with enzyme replacement at the same time. We're not involved in that trial, and we'll see what comes out. I am afraid about Gaucher type 2. I mean, those kids are not normal at birth, and they've got a lot of storage. So I'm not too sanguine that therapies for Gaucher type 2 are going to help, except, maybe gene therapy delivered shortly after birth. But right now, Gaucher isn't on the RUSP anyway, so we're not going to be picking up most of these kids that early unless it's a second affected or, the family got prenatal screening. Yeah, dual therapies, ERT and substrate reduction. Yeah.
Are there any promising biomarkers for metachromatic leukodystrophy?
Sulfatides. I don't know of any other ones.
And you have to have urine.
Um, they were doing something on blood spots. So that I'm not doing the pilot study, but I think that's what they were doing in Europe. It's published now. How to do newborn screening on these kids with a first tier with enzyme assay and then a second tier, I think with sulfatides. It's if anytime you got to do molecular second tier, you're in for a nightmare unless you're New York State. I think that's the way things are going to go, but it's going to take time before we've got either molecular second tier testing or we're doing exomes or genomes on every baby. I think that's a long ways off. We can't even hire a newborn screening lab director. We need one. So we're running the boss of the public health labs is running the newborn screening lab with a senior tech in Georgia since the last director passed away suddenly. We're trying to hire. So if there's any clinical biochemical laboratory people that have done some newborn screening, they don't have to run a lab, but have done it in their training, like they do at Mayo. They do a lot of newborn screening. We're looking for somebody like that. So they're willing to train you up in the management skills and all that kind of stuff you'll need if you've got the laboratory skills to be able to run a newborn screening operation. So if you're got those kind of skills and you want to live in nice warm Atlanta, then I'll help you out. Get plugged in. They're looking. And I believe next year we have an opening for a medical biochemical fellow, because we don't have anybody that's going to be matriculating that's going into it next year.
Other questions for Dr. Wilcox?
We got lots of time, so if you got anything else that you want to ask questions about lysosomal diseases, I'll try. Psychodextrin associated with hearing loss? Yes, it is. That's a known side effect. But Niemann-Pick C can have hearing loss too. Late onset Pompe patients on ERT. So you must be talking about newborn screening. If they come into you and they're symptomatic, you start them now. If they're a newborn screening case, we are following them. If they're, we just had a discussion on exactly how we're going to do this, because we're picking up a lot of them on newborn screening. And I think that the consensus that we're working out, but it will be if they have two very late onset mutations like the intronic splicing mutation, if they've got two of those, we're going to follow them more slowly, less frequently. If they've got a severe mutation and a late onset, then we're going to follow them much like the recommendations that were put out by the Pompe registry. Dr. Kishnani's on that one. And if they're and the same thing if they have a severe and a VUS. That those people, we really don't know when they're going to present. We've got a kid who's got one of those late onset intronic mutations and a severe infantile mutation, who is 2 years old and shows obvious weakness. And we follow them with CK and Hex4, and her CK's been elevated for over a year, and now she's showing demonstrable weakness to the physical therapy assessment, and even just looking at the kid in clinic locking her knees, it's pretty obvious that she's got something going on. And interesting, the SIB, who's a couple years older, doesn't have anything yet. So we're just going to start the younger one who is symptomatic parents don't want to go jumping and start treating them unless they need to, and I understand that. It's really going to change their kid's life. Yeah, and we're using Nexviazyme now. The kid with infantile or this kid that we're with late onset, we're using Nexviazyme, and they start off 40 mg per kg at that young age every 2 weeks. For the infantile onset, we give them, when we diagnose them, we start them right away. And adult Pompe patients can have normal Hex4, yes. So don't count on it. We even got a patient with symptomatic infantile with a normal Hex4. So don't count on your Hex4. I don't know if you need to do enzyme activity for a Pompe patient. In a patient you're picking up if you got clear mutations, but you can do it. It's easy enough to do on a blood spot. Monitor Gaucher disease. Okay. Kaido, I find personally, is the most useful of the easy to obtain biomarkers. We're waiting for Duke to publish their lyso GB1 data that they've been collecting on patients to know how useful monitoring tool. But I mentioned Kaido, and that is not measurable in about 8% of the population have mutation in the Kaido gene. So if they're null, then you can't use that as monitoring. I don't find the ACER trap all that helpful compared to Kaido. So we'll see how LISO turns out. Yes, we're getting approval for Nexviazyme for IOPD. Yeah, we've got a couple of patients who are declining on Lumizyme and switched them over and haven't had a problem. So we'll see. Neurogenic bladder. No, I haven't seen that in Pompe disease. So I'm just reading through the questions in the chat. I don't know if I missed anything.
I think you got them all. Okay. Oh, switching over ERT and an infant who's on weekly 40 per kilo Myozyme at 4 months of age and still poor response.
Yeah, I mean, you could try changing them to Nexviazyme. That's all you got. And make sure they haven't got high titer antibodies. One of our IOPD patients who'd never had antibodies decided to develop them as a teenager, and so he's been on immune modulation therapy, beating back his titer. Yeah, IOPD is just a bad disease. I think we aren't treating the spinal cord, we aren't treating the brain, and they're not normal, and they can deteriorate. They get kind of a amyotrophic lateral sclerosis phenotype. And we've lost some due to that. It's not their muscle weakness isn't just their muscle, it's something else too. I guess we'll see if any of these Trojan horse ERTs that get into the brain are going to be useful for our brain diseases or not.
Great questions. Any more?
IOPD that has infusion reactions that are antibody related or not antibody related, I guess is the question. If they're antibody related, you need to get rid of those antibodies most likely because bad things are going to happen to that patient. If it's non-antibody mediated, then you throw the book at them sometimes. It's non-antibody. Yeah, the mechanism behind that, it's non-classical antibody response, and that's they usually respond to antihistamines and Zofran if they're getting sick to their stomach, steroids if you need it, and if you're in spite of giving steroids at the start of the infusion, which it takes a while to kick in, you can give them a dose of steroids the night before, sort of calm their immune system so that they don't react. And then if that don't work, then you're going to have to slow down their infusion. You may have to try to desensitize them and put them in the hospital for their infusions and just slowly work your way up in rate until they're tolerating it again. Otherwise, you got to hospitalize them every time. We've had some with bad infusion reactions that have had to be desensitized. And our allergists recommend higher dose Zyrtec, cetrizine than again is the usual dose. It's got quite a wide therapeutic range. Still had weakness. Well, your goal with therapy in Niemann-Pick B is to improve the hepatosplenomegaly and the respiratory status. And weakness, it's not really, A would be something different that involves your brain, but B, they just may be so debilitated, you've got to get them physical therapy to get them going. But the goal of therapy is the organomegaly and the lungs. And if they're feeling better, they should be able to get up and get going with physical therapy.
Last call for questions. All right. Well, thank
You
you.
can always email me.
Thank you very much. And I really, really appreciate you taking vacation time to talk to everybody. It's a great lecture. Thank you.
Sure. Take care.
Take care. Have a great vacation. Rest of it. Bye-bye.
Thanks. Bye.